Hello, I'm Dr. Sarah Slocum, and I'm a consult psychiatrist here at Exeter Health Resources. I'd like to welcome you to our next trauma-informed care lecture. This one's on suicide. Over my years as a psychiatrist, I have worked with many people struggling with suicidal thoughts or who have survived a suicide attempt. From young women to elderly men, they all have one thing in common. They acted on an impulse or an idea when they felt backed into a corner with no way out. Suicide is not exclusive to those with psychiatric illness, nor does every psychiatric patient consider suicide. Instead, suicide is one final common pathway, one final outcome when people hit the worst day of their lives and cannot see another way forward. Let's talk about what our goals are when discussing suicide. We have several objectives. We want to discuss the epidemiology of suicide and self-harm. We want to talk about suicide risk factors, both the static ones that are unchanging and the dynamic ones that can change. We want to talk about protective factors. We want to discuss how to perform a risk assessment and how to document these findings. We also need to discuss what statements around suicide and the management of suicidal patients are fact versus myth. As we talk through this lecture, please remember that suicide and self-harm are sensitive subjects. It may be necessary for you to take breaks or discontinue viewing this lecture. It is always reasonable to reach out to our colleagues at the Employee Assistance Program or to your own healthcare providers if needed. There are also hotlines like the National Suicide Hotline at 988, which you can call or text. As we said in our Trauma-Informed Care 101 lecture, language is important. So I'd also like to reframe how you talk about suicide. I encourage each of you to avoid language like successful suicide or committed suicide, which makes suicide sound like an achievement or a crime. Instead, we should utilize language such as completed suicide or died by suicide. While most of this lecture will focus on suicide, we also have to acknowledge that these events exist along a spectrum, from non-suicidal self-injury to completed suicide. It's important to discuss this as well because non-suicidal self-injury has an even higher prevalence rate than suicide attempts. Non-suicidal self-injury is defined as the intentional distraction of one's own body tissue without suicidal intent and for purposes not socially sanctioned. What does that mean? This definition is really describing self-harm actions such as cutting, burning, hitting, or abrading one's skin. For many, this is a harmful distraction that helps them cope with an overwhelming feeling. It can be easier to deal with the physical pain than to sit with the emotion. While self-injury does increase the overall risk of suicide, it's most often performed in the absence of suicidal thoughts. Non-suicidal self-injury is more common in children and adolescents, with a lifetime prevalence of up to 20%. Think about that. 1 in 5 adolescents that you know have struggled with self-injury. Most children have onset of this condition around age 13. Research is ongoing, but has so far shown that self-injury is more common in those who are prone to self-criticism or who struggle to control their emotions. That is partly why talk therapy to gain coping skills can be such an effective treatment method. Although the popular media portrays women as experiencing self-injury more frequently than men, that's actually not true. There are equivalent rates between males and females. However, women are more likely to use methods such as cutting, while men are more likely to use hitting or burning. Non-suicidal self-injury is most often performed in private, in contrast to the popular thought that its function is to be attention-seeking. When you see a patient with non-suicidal self-injury, it is not, on its own, a reason for inpatient psychiatric admission or medications. However, it can and does indicate underlying distress. These patients should have a thorough evaluation of their other psychiatric symptoms, a suicide risk assessment, and discussion regarding psychotherapy or talk therapy. Caring for these patients is twofold. We have to manage the medical complications of their self-injury, such as suturing, giving tetanus vaccinations, etc., and we have to manage the psychologic side of their treatment. Now, let's move further down the spectrum and discuss suicide. Across the world, more than 700,000 people die by suicide each year. The majority of these, around 78%, are in low and middle-income countries. There are noted disparities in gender and suicide completion rates on the worldwide scale. Completed suicide is 3 to 4 times more common in males than females, but females attempt suicide more frequently than males. The discrepancy in this completion rate relates mostly to the means that someone uses during their suicide attempt, which is what we call methodology. Overall, suicide attempts are 30 times more common than completions. Let's bring it down a step. In the United States, almost 50,000 people died by suicide in 2020. That equates to 1 person every 10 minutes, which means that 4 people will complete suicide over the course of this video. Overall, suicide is the 11th leading cause of death for Americans. Of note, between 2000 and 2018, the suicide rate increased by 36%. After a brief drop between 2018 and 2020, the rate is again rising. Suicide rates do vary by age group, with it being the 2nd leading cause of death for some groups, including adolescents. So how does New Hampshire stack up compared to the rest of the country? Unfortunately, we're not doing well. Suicide rates in New Hampshire are 35% higher than the national average, and suicide is the 8th leading cause of death across age groups. More strikingly, it's the 2nd most common cause of death for people ages 10 to 44, coming in only behind unintentional injury from things like car crashes. Like we mentioned, suicide rates are impacted by methodology, which is the word we use in psychiatry to describe what someone uses in their attempted suicide. You can also think of methodology as the manner of death that someone chose. For instance, methods can include firearms, strangulation, overdose, or other means. It is important to discuss some of the basic methodologies because they can be more lethal and therefore pose more of a risk to our patients. Let's talk about some of these methodologies. Firearms in particular are highly lethal or deadly. That's why there is so much focus on firearms when we're safety planning. More than 50% of completed suicides involve firearms, and more than 90% of suicide attempts involving firearms are fatal. So, firearm safety, storage, and access play integral parts in safety planning with our patients. Since there are more civilian guns than people in the United States, firearm safety must also be a routine question for all of our patients in the outpatient, emergency, and inpatient settings. Firearms should always be stored unloaded and locked separately from ammunition. Locking can include chamber locks, trigger locks, and gun safes. If you have firearms in your home, I encourage you to store them appropriately. We all need to make these conversations routine with our patients, our family, and our friends. Suffocation is the 2nd most lethal methodology for suicide, primarily consisting of hanging or strangulation. Overdose is the methodology for 12% of completed suicides. However, overdose is utilized far more commonly in suicide attempts, meaning that the majority of patients that we see may have utilized this methodology in their attempt. The risk of death from an overdose varies widely based on what drug is used, the amount, and whether any other substances such as alcohol are used at the same time. So what causes suicide? Briefly, we can conceptualize suicide as a final common pathway. Think about it like a heart attack. For example, consider someone with a combination of high blood pressure, high cholesterol, diabetes, and an abnormal heart rhythm. Any one of those diseases increases the chances that that person will have a heart attack, and the risk just keeps going up the more risk factors that person has. Suicide is similar. It's a potential outcome for many of our psychiatric illnesses, though it can also occur in people with no psychiatric history. If suicide can be the outcome of so many different diseases, what do we know about what's going on in the brain? The fact that suicide can be a consequence of so many diseases indicates that multiple pathways may play a role. The studies that we do have show that there may be a lot going on, from changes in signaling pathways to changes in brain messengers or neurotransmitters. Some of these theoretical pathways include the hypothalamic pituitary adrenal axis, which is a signaling pathway between the brain and the body. Similar to our substance use disorder lecture, glutamate and serotonin, which are two brain messengers, may also play a role. Some studies show that there is less serotonin in the brains of people who have completed suicide. We don't know yet quite how that comes into play. So the shorter answer is, we don't have all the answers. Much more research is needed on this very important topic. There's a lot more to this than meets the eye. Just because we don't have the neurobiology completely worked out doesn't mean we can't recognize suicide risk and start treatment. Let's start to think about the things that we can see. When I think about suicide, I think about a multi-pronged scale. We balance someone's risk factors, protective factors, and their current mental status to come up with an overall picture of how that person is doing, as well as what their short and long-term risk may be. It can be easiest to break these sections apart when thinking about them. Risk factors are things that increase someone's risk of suicide. Specifically, they can be broken up into static factors that do not change and dynamic ones which can change. The scientific literature further breaks risk factors into certain age groups. Let's start with some static risk factors. Do you think that different ages are at different risks for suicide? What about people who have a family history of mental illness or suicide? Do prior suicide attempts increase one's future risk? The answer for all of these is yes. Suicide risk is highest overall in the elderly, although younger patients ages 10 to 44 are also at elevated risk. Males are at higher risk than females across the board, and having a history of physical or sexual abuse raises everyone's risk. Now let's talk a little bit about risk by age. In kids, risk factors include identifying as LGBTQ, with transgender youth being 4 times more likely to attempt suicide than their peers. We must note that this increase in suicide risk results from how these youth are treated and marginalized, and not inherently because of their gender identity. Other risk factors for children include being a witness to violence, suicidal behavior, or completed suicide. In adults, Caucasian race, military service, and a history of being arrested raise someone's risk. Further, having less than a high school education can be a risk factor. In the geriatric age range, chronic medical conditions come into play. Those are a lot of risk factors that we cannot do anything about. We can't change someone's age, personal, or family history. This is where dynamic risk factors come in. Dynamic risk factors are those which can change, either with outside support or from the patient themselves. These are particularly important because they indicate areas where we as healthcare staff can intervene to decrease someone's suicide risk. When we think of dynamic suicide risk factors, we should think of how someone is doing at that point in time. Are they currently depressed? What stressors are going on in their lives? Are they having any acute medical illness? Again, all of these things can increase suicide risk. Other things that increase risk across the board include having a current psychiatric illness, with depression being the most common. Symptoms like impulsivity, access to firearms or other lethal means, and social isolation. In kids specifically, conflict with parents or romantic partners, and bullying, either being the bully or the victim, raises risk. Legal trouble and active substance use also raise the child's suicide risk. In adults, symptoms such as agitation, insomnia, or trouble sleeping, and hopelessness come into play. Being single, divorced, or widowed, as opposed to married, raises an adult's risk. Active military personnel, particularly the Army, being a lower rank and having a history of a traumatic brain injury, raises risk. Recent arrest or incarceration, job loss, financial stressors, and romantic conflict raise an adult's risk. In the elderly, feeling like a burden, feelings of guilt, and acute medical illnesses raise risk. Remember, dynamic risk factors are very important to identify because these are areas where we can have a targeted impact to decrease someone's suicide risk. It's a myth that asking about these risk factors makes suicide more likely. That's simply not true. Asking does not make suicide more likely. we cannot know where to intervene without asking the question. I also want to take a minute and talk about the particular risk factor that the COVID-19 pandemic has posed. Remember how we just talked about social isolation being a dynamic risk factor, especially in the elderly? Well, we did see a shift in those persons with suicide attempts and completed suicides during the COVID-19 pandemic. This was particularly true for elderly patients, even those who had no past psychiatric history, but who experienced significant social isolation in the early days of the pandemic. While much of our society has returned to normal function, we must keep this lesson in mind for future times of social isolation. Let's move on to the second part of our scale, protective factors. Protective factors are exactly what they sound like, the things that someone enjoys so much that they make it less likely for that person to complete suicide and more likely that they want to stay alive. Again, protective factors can vary by age group. In children, fondness for school, participation in sports, good coping mechanisms, and connectedness to family are important. There is some change by gender. In male youth, having a religious affiliation, a high GPA, and more people living in the household, as well as having high school expectations, are protective. In young women, emotional well-being, the availability of counseling at school, and having parental presence at key times of day are important. In adults, we see a significant fear of social disapproval or death, and that stigma can actually be protective. Being married or having children also plays a role. Active participation in treatment, medication compliance, and a good therapeutic relationship with providers is protective. Religious affiliation and supportive social networks protect patients throughout the geriatric age range. Overall, one of our biggest protective factors involves our ability to create and maintain in-person connections with others, including healthy relationships with family and friends. Having a good therapeutic relationship with healthcare staff, whether it be a physician, therapist, or others, is also protective. So you can see how social networks play such an important role here. And we're referring to the human-to-human interactions and reliable relationships that exist in people's lives. I want to make that distinction so that we don't confuse social networks with social media. Social media is not a substitute for a social network. Now, let's think about the third component of this scale, the mental status exam. For providers, the mental status exam is thought of as the psychiatric physical exam. The mental status exam consists of categories such as appearance, behavior, speech, language, thought process, thought content, orientation, insight, and judgment. The overall goal is to document how and what that person is thinking and feeling, and how they're behaving at a given time. We want to get the big picture of how someone's mental health is on that day. For instance, mental status exams should state whether someone is having suicidal or homicidal thoughts, hallucinations, and whether they know where and when they are. It should also comment on how someone is thinking, whether their answers make sense for the questions asked or not. A well-documented mental status exam should paint a picture in your mind's eye of how that person is doing at that moment in time. Let me give you an example. If I document that my patient is a 30-year-old female, casually dressed with blonde hair and glasses, sitting calmly in a chair and speaking in a normal tone and volume, that already tells you a great deal about my patient. Conversely, if I tell you that my patient is disheveled with unkempt hair, they're malodorous, and they're using a loud volume, that paints an entirely different picture. Why do we need to paint that picture at all? Well, because a risk assessment is meant to combine risk factors, protective factors, and the mental status exam to serve as a basis for a clinician's judgment on a patient's level of risk. When I do risk assessments, I tend to break this apart into acute and chronic risk. For instance, someone could be at high risk acutely if they just lost their relationship, their job, or something else in their life. But that risk might decrease with time after they get a new job or have time to process their experiences. There are a few incredibly important things to take away from a risk assessment. Firstly, the best predictor of future behavior is past behavior. Let me say that again. The best predictor of future behavior is past behavior. Secondly, despite what we just discussed, no one is able to actually predict the future. There's no current assessment which has the ability to calculate someone's exact suicide risk based on input. Unlike some of our calculators for stroke risk, heart attack risk, etc., we just don't have that. The best we can do is to use our collective clinical judgment in educated estimation and solid documentation. So after you've assessed someone's risk, what do you do next? This moves into what we call risk mitigation. Risk mitigation is similar to the harm reduction that we talked about in our substance use disorder lecture. Risk mitigation can range from complex interventions like hospitalization all the way down to simple daily changes. Perhaps the most important tenet for suicide risk mitigation is to delay the impulse for suicide. Did you know that 50% of completed suicides occur within 10 minutes of considering suicide, and 70% occur within an hour? So if we can delay people from acting by just 10 minutes, we could prevent up to 50% of completed suicides. The question then becomes, how do we get to those 10 minutes? One of the easiest ways is to limit access to lethal means. This could include gun safes, including trigger or chamber locks, time delay safes, and medication safes. Removing firearms from the home is even safer, but it's not realistic for all of our patients. Working with the patient to create a personalized suicide safety plan is one of our strongest mitigating factors. In fact, there's even a phone application called Suicide Safety Plan, which allows our patients to enter their own warning signs, coping strategies, reasons to live, and contact information for when that person is in crisis. What else can we do to decrease someone's suicide risk? One option is to involve trusted friends or family members. This actually serves two purposes. It lets the healthcare team gain collateral information from those people while also allowing us to educate them on warning signs and when to encourage the patient to seek higher levels of care. We can then provide resources to both the friends and family members as well as the patient themselves. We can also offer medication to help a patient treat their symptoms. Sometimes this is in the form of a daily medication for ongoing symptom management, and sometimes it's on an as-needed basis that the patient can take only when they're feeling certain symptoms, such as anxiety or trouble sleeping. We can also offer alternate levels of care, such as outpatient psychiatry or psychotherapy, intensive outpatient programming, partial hospitalization, or inpatient psychiatric hospitalization. When considering what level of care someone may need, it can be helpful to involve psychiatric clinicians. For inpatient hospitalization specifically, the patient should have a modifiable dynamic risk factor to be addressed. Inpatient hospitalization should not be used only as a holding environment for the patient. For those who have never seen an inpatient psychiatric hospital, these are frequently locked units where patients have the ability to move around, visiting recreation rooms, a cafeteria area, etc. There's often groups that run throughout the day focused on cognitive therapy, psychoeducation, coping skills, or recreation. Patients typically meet with their psychiatrist or treatment team once a day, and nurses and mental health technicians are present on the unit. When in those hospitals, patients do not frequently require extra observation. However, in the medical hospital, patients may require additional observation because there are inherently fewer safeguards in this environment. For instance, if the patient is actively suicidal in the medical hospital, we may utilize a one-to-one sitter to monitor that patient's safety. Alternatively, options like teleobservation or watching the patient through a camera or frequent nursing checks can be possible additional levels of protection. So what do you do when you're outpatient? Well, we start with screening. All of our patients should be screened at least annually with the PHQ-3. This is a brief 3-question depression screen, which expands to a 9-question PHQ-9 version with any positive response. The screeners are meant to pick up on depressive symptoms that patients may be experiencing, so that clinicians can assess for a diagnosis, severity, and treatment options before things get severe. There's a question in the screen about suicidality, and if someone indicates a positive response to thinking about suicide, that has to be followed up on before that person leaves the visit. We have had positive screens within CORE, which were managed appropriately in real time and have resulted in patients receiving potentially life-saving care. So how does one do this? How do you determine who can go home, who should go to the emergency department voluntarily, and who might need to go involuntarily? A lot of this depends on your role within the organization. Regardless of where you are, your first job is to ensure your safety and the patient's safety, and then just listen. If the patient is calm, safe, and ready to talk, take a seat and hear them out. Asking questions about suicide does not increase someone's risk of completing suicide, nor does it increase the risk of that person harming you. So it's safe to have this conversation. There's a specific training called QPR, which is basically CPR for suicidal patients. QPR stands for Question, Persuade, Refer. Its steps are simple. Ask questions about what someone is thinking, why, and if they have a plan. Attempt to persuade them to seek help, including with emergency services if needed. Then, refer them to the closest and most appropriate access point for aid. QPR gatekeeper courses take only an hour and are low cost. If you would like to learn more, please check out the QPR Institute's website. As you engage with suicidal patients, one of the most important things to do is to impart hope. Remember how I said that suicide is what happens when someone's having the worst day of their life and they can't see another way forward? Our job is to delay that, to show them that there is hope. Hope can come in many forms. For some, it comes as medication to treat a psychiatric illness. Which medication is chosen depends on that person's diagnosis, so we won't discuss the specifics here. Another road to recovery is psychotherapy or talk therapy. There are many different forms of talk therapy, from structured forms like cognitive behavioral therapy to less structured supportive talk therapy. Another option, like creating a safety plan, is great. Safety plans list the steps that someone should take when they're feeling suicidal. Not everyone's path to hope is the same. In the moment, there are several things that we can tell these patients. We can say, I'm here to help. I want to hear what you've experienced. I'm going to stay with you. Your life matters to me. It doesn't take much to impart some hope. Now, to shift gears a little, we also have to discuss documentation. In healthcare, what we do has to be documented, both as evidence of our work, but also as a message to our colleagues who care for the same patient at a later time. Accurate documentation is absolutely essential for continuity of care and successful transitions. Here are some general rules for documentation. Don't use slang, don't be judgmental, and don't speak badly of other hospitals. Never copy and paste without editing. You should always be specific. State what you saw and consult with others when needed. Document everything you did, even if it wasn't successful. For instance, if you tried to call a patient's family but they didn't answer, document that. If you offered medication and the patient refused, document that too. You should always state what you did to mitigate or lessen that person's risk and what has occurred in prior similar situations. Let's listen to a few documentation examples. Number 1, 24-year-old borderline presents with cutting, again, after more fighting with her boyfriend. Same presentation as the other 5. Compare that to number 2. A 24-year-old with a past psychiatric history of borderline personality disorder presents with non-suicidal self-injury by cutting in the setting of relationship difficulties. Of note, the patients had 5 prior similar presentations. Or try this. Number 1, risk is low, proceed with discharge. Number 2, the patient's overall risk for intentional self-harm is judged to be acutely low given the lack of current suicidal thoughts, no history of attempts, lack of abuse, no access to firearms. Protective factors further include good rapport with their psychiatrist, medication compliance, sobriety. They're married with a supportive spouse and adult children nearby. The risk is further mitigated today by a therapeutic interview. The patient's appropriate for continued outpatient care after medical discharge. Take note, the short one gives next to no information to the next care team besides your opinion that the risk is low. The second, however, is invaluable. It calls out specifics so that a care team in 2 years can identify exactly what has changed to alter that risk level. Now, let's test your knowledge around some common misconceptions about suicide. Here are a series of myths versus facts. Some of these were covered in this presentation, but others weren't, so don't be distressed if it's new information. Ready? Let's go. Suicide attempts are more common in females. Myth or fact? This is a fact. Women are more likely to attempt suicide and more often utilize overdose as the method. However, men are more likely to complete, likely because they're more frequently using firearms. Some subgroups are particularly high risk, including military veterans and female physicians. Safety contracts, which are a piece of paper that the patient signs stating that they will not attempt suicide, are helpful protective factors. Myth or fact? This is a total myth. While contracting for safety might make providers feel better, these contracts have not been shown to improve outcomes or actually decrease completed suicides. Safety planning, however, can help mitigate risk. Safety planning is what we talked about before. They're interventions that are listed out for what someone can do when they're in crisis. Safety plans can detail a combination of the following: a patient's medication list, community resources, including county, state, national, and private crisis lines, a list of upcoming appointments, people to call and their phone numbers for times of crisis, things to do in times of crisis. This can be highly creative and tailored to the person. I once had a patient who loved Harry Potter, so we came up with an entire Harry Potter-related crisis plan. Safety plans can also list common triggers for that patient and plans to avoid them if possible. Next, asking about suicidal thoughts or behaviors increases a person's risk. Do you think this is a myth or fact? This is a myth. Asking allows us to mitigate risk. It destigmatizes mental health concerns and it can help those in need. Asking does not suggest suicide. Here's another. Once someone's suicidal, they're always suicidal. Myth or fact? This is another myth. Suicide is often impulsive. It's situation specific. Most people who complete do so in the setting of the worst day of their life when they cannot see any other options. Remember that impulsivity can last for just 10 minutes, so delaying can really save a life. Next, antidepressants increase suicidal thoughts. Is this a myth or a fact? This is kind of a trick question because it might be both. There's a black box warning on some antidepressants called selective serotonin reuptake inhibitors in children and adolescents for increased suicidal thoughts and behaviors. This was based on something called a meta-analysis of more than 372 studies and 100,000 participants. Suicidal thoughts occurred in 4% of those receiving an antidepressant, but only 2% of those receiving placebo. But the study was kind of flawed. It was very difficult to control for how severe someone's illness was, as well as what confounders exist across that number of studies. Logically, people with more severe disease are more likely to receive treatment. The results of this study led to fewer depression diagnoses and less treatment. Meanwhile, the suicide rate in youth continued to climb. So do not let this warning dissuade you from starting depression treatment. Here's another. You have to have a psychiatric illness to be suicidal. Myth or fact? This is a myth. Suicidal behavior can occur without a diagnosable primary psychiatric illness. It's also important to know that not all people with psychiatric illness experience suicidality. What about this one? Copycatting suicides occur. Is this myth or fact? This is a fact. It's termed the Werther effect, and it describes the relationship between the celebrity suicide rate and the national suicide rate. Interestingly, this effect is speeding up as the digital age continues. The magnitude, though, is getting smaller, with some people stating that this is because suicide is being normalized. And when does this effect happen? It's actually most prominent in the month of media coverage, but it persists into the following month. What about this one? Most suicides occur without warning. Myth or fact? This is a myth. The majority do have warning signs or elevated risk factors. Some particular red flags include things like giving away possessions, talking about suicide in a different way from baseline, stockpiling medication or attaining other lethal means, or a sudden improvement of mood in someone who's chronically depressed or dysphoric. Now, let's wrap up. Suicide rates are climbing, making this an important consideration in healthcare today. Suicide's now the second leading cause of death in people ages 10 to 44 and is also a leading cause of death in the elderly. I really want you to take away 3 important things from this lecture. Number 1, suicide is impulsive. It's something that happens when you're on the worst day of your life and you can't see another way forward. This impulsivity is impacted by lethal means, things like firearms and access to medications. Being able to delay that impulse by just 10 minutes lets us save numerous lives. So keep that in mind as you're counseling your patients and asking them about firearm and medication storage practices. Number 2, asking someone about suicide does not increase the risk that they're going to complete suicide. Instead, it allows you the chance to intervene and to help that patient. Number 3, suicide safety planning is a key thing that we can do to decrease someone's risk. These safety plans involve crisis numbers, people that they can contact when they're in crisis, as well as things that they can do on an individual level to distract themselves and to get over that impulse. I hope that after this lecture, you feel comfortable helping care for these patients, that if it's safe, you can sit down, you can take a seat, and you can remind that person that they're not alone, that you're there to help them. Thank you so much for your attention, and we hope that you view our other trauma-informed care modules as well.